Next session will be trabeculectomy by Dr. Kiran Gopalakrishnan.
Thanks, Dr. Roshni, for the invite to speak here. So I'll be discussing about a few surgical pearls in trabeculectomy in the context of angle closure disease. Now, trabeculectomy has been the most popular filtration surgery for angle closure glaucoma for good reason. Studies performed in the long term in whichever geographical area you choose. As you see here, a study in South Korea over 15 years has a qualified success rate of about 75%. A study published from RP Center in India has a qualified success rate of 88% at 10 years. So this is an amazingly successful surgery. But even in the best hands, trabeculectomy has its complications. Now, if you look at the primary TVT study, which only dealt with trabeculectomy in open angle glaucoma patients, but I put it here because even in open angle glaucoma patients, trabeculectomy in the hands of some of the best glaucoma surgeons in the world still has a reasonably high complication rate of around 41%, out of which 33% were early complications, and most of which could be managed in the office itself. But there were around 8% of patients with serious complications like vision loss and people who had to be taken up for resurgery. So which complications are more likely to occur in angle closure glaucoma traps compared to open angle glaucoma traps? You are at higher risk of developing a shallow or flat anterior chamber. You are more likely to encounter aqueous misdirection or malignant glaucoma, and the cataract formation acceleration is again much faster in traps in angle closure disease. So we will try and look at certain surgical pearls, which are basically steps that you would do in any trap, whether it is open angle or angle closure, but has special emphasis on angle closure glaucoma traps. First is preoperative mannitol. Now, mannitol dehydrates the vitreous and therefore can have a good impact on reducing the positive pressure during surgery. And this will basically make your surgery a little more smoother and less messier if you have less positive pressure during surgery. And the important thing to note is that its peak action is in about 30 to 60 minutes. So you don't want to give the patient mannitol 3 hours before surgery or too late before you take the patient up for surgery. And the dose is about 20 ml per kilogram body weight. And since the drug induces diuresis, it's always a good idea to tell the patient to go to the bathroom before you take the patient up for surgery. In older patients, I usually suggest diapers, because the positive pressure reduction that you obtain from mannitol can be counteracted by the straining if the patient is on the table and is straining to pass urine. Now, second is optimizing the use of mitomycin C. Now, how can you optimize mitomycin C use? There are two things here: concentration and exposure time. So various concentrations have been studied, less than or equal to 0.1 milligram per ml, 0.2, 0.4 and above. So multiple publications have looked upon this. And generally you find that at less than 0.1 milligram per ml, the efficacy of your traps actually become low in terms of its success rates. At 0.4 and above, the complications tend to become higher. All the complications I described above are going to be likely higher with 0.4 and above, and therefore a reasonably good compromise of concentration will be 0.2 milligram per ml. And as far as exposure times are concerned, 1 minute, 2 to 3 minutes and 3 to 5 minutes have been looked at in multiple publications. Generally at less than 1 minute, the efficacy actually is lower. At 3 to 5 minutes, it usually makes no difference because the tissues are already completely saturated with mitomycin by around the 2 to 3 minute time frame. So again, 2 to 3 minutes seems to be a good compromise. If you are using injectable mitomycin, which in preliminary data does show equivalent efficacy to using sponges, then this may not be of, this exposure time may not be of such significance. Now coming to scleral flap creation. Now the important thing to note when you create this scleral flap is you should not end up with a thin scleral flap because the risk of shallow flat chambers hypotony is going to be much higher in a thin scleral flap. So you should obtain a reasonable plane of at least 50% or more scleral thickness. Now you can do the scleral flap in multiple ways. You can basically initially get a good plane. I use a combination of both tunneling I don't usually tunnel all the way right up to the cornea, but I use a combination of both tunneling and some degree of dissection under direct visualization as the scleral flap becomes closer to the trabecular meshwork. Irrespective of the technique, make sure you get a thick scleral flap. A pre-placed suture. Now this seems a very innocuous step, but a pre-placed suture helps you to basically close the flap much faster once the sclerostomy is made, because once the sclerostomy is made, the eye tends to become hypotenuse. It's much more difficult to pass the suture, and this shallowing of the chamber post sclerostomy creation is going to be much more prominent in an angle closure trabeculectomy. Next, again, a simple thing, paracentesis. Before you create the sclerostomy, just make a paracentesis. Now, once you do the sclerostomy, as I said, in angle closure glaucomas, the shallowing of the chamber can be quite aggressive, and you have to now reform the chamber. The sclerostomy opening is much larger in size compared to the paracentesis opening. It's easier to reform the chamber through a paracentesis opening. So it basically gives you much better control of the anterior chamber intraoperatively, and post-operatively, if you want to reform the chamber in the case of a shallow or a flat chamber, it is easier to use the pre-existing paracentesis rather than create a new paracentesis in the setting of a hypotenuse flat eye. And some people do chamber reformation in the office itself, in which case you have to basically look at the direction or the clock cover where you are going to create paracentesis and make it about 3 o'clock in the left eye and 9 o'clock in the right eye to facilitate easy access from the slit lamp. When you make the sclerostomy, whichever technique you use to make sclerostomy, whether using a punch or whether you are making a sclerostomy using the technique I show here, where I use a sharp MVR blade to delineate the two sides of the sclerostomy and then use an angled vanas to make the intervening cut, you make sure that you go slightly anterior and not end up damaging the root of the iris and the ciliary body. This will accelerate the risk of hypotony and also increase the risk of aqueous misdirection in the post-operative phase. Releasable sutures. Now, releasable sutures, there are various techniques of using releasable sutures. Once you make the scleral flap, you close the scleral flap with either only releasable sutures or a combination of both interrupted sutures and releasable sutures. There are various techniques. I am not going to the details of the techniques, but I tell you that the use of releasable sutures in angle closure glaucoma traps, especially in all traps in fact, is a no-brainer, because there is clear literature evidence, and everybody who has put releasable sutures will attest to their own personal experience as well, that the rates of hypotony, flat chambers, choroidal effusion, all these can be reduced by sometimes between as much as 2.5 to 4 times if you put releasable sutures. Now you can wonder, if I put scleral flap sutures very tight and make a large number of sutures to close the scleral flap tightly, also you can reduce the risk of hypotony, flat chambers and choroidal effusion, but that would actually impact the success of the trap because it will interfere with filtration. But with releasable sutures, the complete and qualified success rates are not altered. So it reduces complications and maintains success, the twin things that is the holy grail of any procedure. Cycloplegic therapy. Now, it's always a good idea to give a subconjunctival dash of atropine at the end of an angle closure glaucoma trap. And the reason why I say is, aqueous misdirection or malignant glaucoma is so much more common in angle closure glaucoma traps. In fact, this study retrospectively looked at 27 consecutive cases of malignant glaucoma and found that all of them had a primary diagnosis of angle closure glaucoma. And when they looked at the UBM images of the fellow eye, all of them had an anteriorly rotated ciliary body in the fellow eye as well, which means the other eye, whenever it undergoes trap, is going to be at higher risk of malrotation. So intraoperatively, subconjunctival atropine plus postoperative cycloplegic therapy for a couple of weeks is a good idea in angle closure glaucoma traps. And finally, if the patient with angle closure glaucoma has a whiff of cataract, whether it is a very advanced cataract like this, where you're obviously going to take out the cataract, but even with much lesser cataracts, lens does contribute significantly, and it's always a better idea to do a cataract surgery first and then go ahead with the trap at a different site, as I do. But irrespective of the contribution of the lens, post-operatively, your life is much more easier once the lens is taken out in a trabeculectomy, because it will reduce the risk of flat chambers and hypotenuse eyes. To conclude, while you look at 8% serious complications, you have to look at the 88% success at 10 years. And you think that these are patients who would have actually gone blind by 10 years because they were offered trabeculectomy in the first place because there was no other option. So all of these patients, almost all of them at 10 years would have gone blind if not for the success of trabeculectomy. Thank you.
Thank you, sir. That was indeed informative, especially for those who struggle with trabeculectomy